Hello. Hello. So, good evening, all, and welcome to our 87th National Webinar held by the Believers Webinar and Clinics Committee. Today, we are going to dive into the world of anesthesia. We have got an interesting talk coming up. And at the onset, let me introduce to you our moderator for the day, Dr. Jinsi Ann Lukachin. She's working here as an assistant professor in the Department of Anesthesia, a very excellent clinician. She has got a lot of research papers, and I welcome you, madam, to this webinar. Good evening, madam.
Good evening, everyone. Thank you, Dr. Vivek, for the introduction. The topic for today's webinar is the challenges in anesthesia during bariatric surgery. There is an increasing prevalence of obesity in adults, adolescents, and children. The WHO has declared obesity to be a major public health hazard and a global epidemic. It might be surprising to know that in a study published in the Lancet, India is ranked third in the just behind US and China in the top 10 countries with the highest number of obese people. We all know that obesity has a lot of health hazards like hypertension, diabetes, heart diseases, stroke, sleep apnea, increased risk for cancers, right? So this means that the management of obesity is really important. Along with lifestyle interventions, bariatric surgery is gaining a lot of prominence. For a super obese patient, bariatric surgery is not just for a cosmetic reason. It is a life-saving surgery. So for an obese patient coming for surgery, the conduct of anesthesia has a lot of unique challenges, which we are going to deal in detail. It is my immense pleasure to introduce the speaker for today. It is none other than Dr. Ashu Saramathai, who is the professor and head of the department in anesthesia at Believers Church Medical College Hospital. She was previously working as headed the critical care unit in CMC Ludhiana, and she joined Believers Hospital 6 years ago as professor. She is an astute clinician and an academician par excellence. She has extensive experience in managing difficult and challenging cases. As the panelist for today's discussion, I introduce Dr. Sujit Philip, who is the senior consultant in gastrointestinal and hepatobiliary surgery. He is a very experienced surgeon doing bariatric surgery, complex hepatobiliary, and colorectal surgeries. And before we go on to the topic proper, I would like to ask the participants, the listeners, to drop in your questions into the chat box to be discussed at the end during the question answer session. And over to you, Dr. Ashu, for the topic.
Thank you so much, Dr. Jinsi. It's indeed a pleasure and an honor to be able to share a few thoughts and some of my experiences on the management of on the management of obese patients coming in for bariatric surgery. So without any further delay, let me share my slides. Yeah, so the topic of the day is challenges in anesthesia during bariatric surgery. What are our concerns as far as the anesthetist is concerned? What are the concerns that come to us when we are faced with a patient coming in for a bariatric surgery? We know that before we go into the concerns, let me just briefly tell you about the categories of weight or categories of obesity as we define them now. We know that the BMI of a normal individual could vary between 18 to 25. And an overweight individual would have a BMI of 25 to 29. And then obesity is classified further as class 1, 2, and 3, ranging from BMI 30 to BMI more than 40. And we know that now in the ASA classification, that is the American Society of Anesthesiologists classification, obesity has come in the ASA grading. So anyone with a class 2 or a class 3 obesity would come under a higher risk as far as ASA grading is concerned. So why is this so? Why is obesity such a concern for us? We know that morbidity and mortality increases sharply when the BMI is more than 30, particularly in smokers and men. Someone with a BMI of 35 with comorbidity or a BMI of more than 40 without significant comorbidity would definitely be a concern as far as the anesthesiologist is concerned. Now, why in males? Why are we more worried in that subgroup? Because we see more of an android fat distribution in them. So we know that an android fat distribution is going to tell you that there's going to be more intraperitoneal fat, increased fat deposition around the neck and the airway, which predicts a difficult airway management and a difficult ventilation of the lungs. These patients are also at a greater risk of metabolic and cardiovascular complications. Obese patients, obesity is associated with hypertension, dyslipidemia, ischemic heart disease, diabetes, liver disease, and asthma. So that adds to our concern as far as the anesthetic management or the perioperative management is concerned. We know that most of these patients will have obstructive sleep apnea or obesity hypoventilation syndrome. Why does this happen? We know that as the BMI goes up, there is a desensitization of the respiratory center. And rather than a response to carbon dioxide, these patients have an increased reliance on hypoxic drive. That is what drives their respiration. And so when you give depressant drugs to these patients, for example, sedatives or opiate analgesics, they have a reduced response as far as the ventilation is concerned. We also know that these patients are hypoxemic at rest, and this is worse when they get into the supine position or further still in the Trendelenburg position. They rapidly desaturate when conditions of apnea exist. And we also know that lung compliance is going to be decreased. And all of this is going to be worse when they're supine and even more worse when they're going to be under anesthesia or under GA. We know that these patients have airway closure, which is very early, and V2 mismatch. Now, if this was bad, these conditions are going to get worse when we begin pneumoperitoneum in these patients. So under the conditions of pneumoperitoneum, the loss of compliance is accentuated, diaphragm gets splinted, and airway resistance is increased. All of this adds to our concern when dealing with morbidly obese patients. The effect on the lung. What is the pulmonary dysfunction that we're talking about? These are the patients who have a higher demand but a poorer supply. So the demand-supply ratio is completely imbalanced. Why is there an increased demand? We know that there is an increased oxygen consumption in these patients with an increased carbon dioxide production. So because of this, even at rest, there is an increased alveolar ventilation. Coming to the supply side, there's an increased supply requirement because of there is a decreased supply of oxygen to these patients because of decreased chest wall compliance, increased work of breathing, decreased respiratory muscle efficiency, and premature airway closing. So all of this leads to arterial hypoxemia. This is the classic text that we have studied in most of our postgraduate programs, where we know that whereas a normal non-obese patient would have his FRC well above the closing capacity, as in the obese patient, the FRC starts encroaching into the closing capacity, which means the airways will close, the alveoli will close much below the FRC. And this gets worsened in the supine position and when the Trendelenburg position is acquired in these patients. What about the cardiovascular system? In morbidly obese patients, we know that the blood volume, the total blood volume, the cardiac output, the ventricular workload, the oxygen consumption, and CO2 production are all increased. And this is because blood is now having to fill the vast fat deposits of the body and the tissue beds therein. So because of this, the in total blood volume of the patients is grossly increased. And there is an increased demand on the left ventricular filling and stroke volume. These patients are also at a risk of arrhythmias because of myocardial hypertrophy and hypoxia, hypokalemia, coronary artery disease, increasing circulating catecholamines, and there's actual fatty infiltration of the conducting and pacing systems in the heart. All of this results and is aggravated by arterial hypertension. We know that hypoxemia could lead to polycythemia over time when this becomes chronic, and increased metabolic demands leads to an increased blood volume contributing to increased arterial pressure. There is increased activation of the renin-angiotensin-aldosterone system, which also leads to vasoconstriction and hypertension. As a result of hypertension, there is LV hypertrophy, which if long-standing and if not corrected with other measures or if not treated appropriately, could lead to biventricular failure. So as far as the obese patient or the morbidly obese patient is concerned, our main concerns are going to be the cardiovascular system and the respiratory system. But we also must remember that there is derangement of many other systems. For example, the CNS, or the metabolic function, or the coagulation function, or the bone and joint functionality, and gastroesophageal reflux diseases. So we have to remember that all these components are going to come into play when you are going to be anesthetizing these patients. We have the obesity surgery mortality risk score that is validated for use in bariatric surgeries. And this is going to help you decide where you're going to keep these patients after your surgery is over. So if the patient has a BMI of more than 50, is a male, is a hypertensive, and is older than 45 years, and if he has an increased risk for pulmonary embolism, for example, a previous venous thromboembolism, if he has a vena cava filter, if he has a history of OSA or OHS, so all of these factors, you would have to give a score of 1. And when you add these points, if a score of more than 4 to 5 is there in a particular patient, that indicates that this patient is going to be high risk. And you should probably consider admission to a critical care unit after the surgery is over. So that's a useful predictor. Now, coming to the other problems that anesthesiologists face, is that's going to be calculation of appropriate dosages of drug. Should you calculate drug doses according to the actual body weight, according to the BMI, according to the lean body mass, or is it going to be the adjusted body weight or the ideal body weight? So that's a whole conundrum there. And to an extent, for example, to an extent of a BMI of 50, some of these articles actually tell you what you can base your dosage guidelines on. But beyond a particular BMI, if the BMI is more than 50 or 55, we're lost. We don't know how to actually calculate many of our drug doses because there's a host of issues that comes into play. The volume of distribution of the drug, the decreased fraction of the total body water, increased adipose tissue, increased lean body mass, altered tissue protein binding, etc., etc. So that is going to be another area where some of us might struggle with. And the most important factor that we would like to emphasize here is that the management of the obese patient, particularly the obese patient, can never be a 1 or 2 department management. It has to be a multimodal approach, and teamwork cannot be overemphasized. The endocrinologists, the pulmonologists, the cardiologists, the GI surgeons, the physiotherapists and the physiatrists, the anesthesiologists, the dietitians, the clinical psychologists, and the nursing, each has a very important role to play. And unless we work as a team, we are only as strong as the weakest link. And everybody must contribute so that we have a healthy, happy, and safe patient going home. We know that ERAS is coming to a big way in bariatric surgery. The ERAS protocol defines many of these stages. It specifically gives us inputs into how each of these phases can be managed. ERAS defines pre-hospital phase as educating the patient and planning the pain management even in the pre-hospital phase. And so you optimize the patient as well as you can before you admit the patient for a bariatric surgery. And prehabilitation and exercise training of these patients is very important. In the preoperative phase, ERAS guidelines suggest that we limit fasting, encourage oral fluids, and limit IV fluids. So that means you give a carbohydrate beverage up to 2 hours before so that you can prevent the catabolic phase. And then continue patient education throughout. The intraoperative phase includes opiate-sparing analgesia, normovolemia, making sure that nausea vomiting prophylaxis is provided, ensuring normothermia and normoglycemia. And then we continue management in the postoperative phase by early nutrition, early mobilization, continuing with opiate-sparing analgesia, managing nausea and vomiting, and continuing with patient education and encouragement. And then post-discharge, we follow up with all of this. So let me talk about some of the aspects of this in more detail, especially for an anesthesiologist. How can you contribute right from the pre-operative or the pre-hospital phase? A very important point to remember is that we must make a conscious effort to avoid fat shaming. Very often by mistake, we refer to patients as, oh, that fat person or that fat woman. And not only is that rude, but it is also counterproductive to the shared decision-making goals that we would have. We want to treat that person as an individual, and we are together trying to help them. So let us avoid, as far as possible, consciousness, make a conscious effort to not talk about, not fat shame that patient. Also, remember that while dealing with patients with morbid obesity, we need additional operating room personnel. And all operating room staff should be involved in the care of the patient, including the technicians and the nurses who are in the operating theater. And we must ensure that we have adequate equipment to safely transfer and position the patient. And for this, doing a mock drill is sometimes very important, especially when you're starting off doing morbid obesity surgeries and when we are faced with challenging surgeries. A safety briefing and a mock drill is very important. We must also be prepared with a theater table which will allow maximum weight allowance. And where possible, encourage the patient to maintain their own mobility. For example, walk the patient into the theater. Make sure that they're wearing socks and then walk them into the theater and allow them to position themselves on the operating table. So not only are you ensuring a safe position, but you're ensuring that normothermia is maintained right up to the point that they come to the operating table. Of course, we cannot overemphasize the importance of adequate padding and gel pads to protect pressure points. There must be enough trained and experienced staff, like I mentioned earlier, to assist you with moving the patient should it become necessary during induction, if you have to do management of an unexpected eventuality. DVT risk assessment and management with compression stockings and DVT pumps is also important. So the positioning that the patient acquires when taken up for a bariatric surgery would be a sniffing in the morning air position, which is a RAM technique. Which means that the patient is placed with adequate padding so that the earlobe and the sternal notch are parallel to the ground. Also, we must make sure that the arms and feet are supported and they're well padded to prevent neural injuries. As I mentioned before, the operating table should be special bariatric operating tables, which can take the high capacity load, especially when you're going to give particular positions to the patient. What about intraoperative? What are the things that we should take care of intraoperatively? The most important being protective intraoperative mechanical ventilation. What does this contain? This means this is a combination of low tidal volume, appropriate PEEP, and low driving pressure. That is safe ventilation. It has been proven to reduce incidence of postoperative pulmonary complications. It decreases hospital stay and decreases mortality. What is the best PEEP to use? That's a good question, but there is no right answer there because the best PEEP is what is right for that particular patient. It's basically the PEEP which will avoid overinflation or hyperinflation, at the same time maintain optimum alveolar recruitment. So you have to balance oxygenation, alveolar recruitment, and avoid hyperinflation and overdistension of the lung. The current recommendation says that we maintain tidal volumes of 6 to 8 ml per kg, plateau pressures below 30 centimeters of water, and titration of PEEP guided by the patient's respiratory and cardiovascular state. Very often we use a PEEP of 10 to 15 centimeters of water. What are the goals and recommendations for ventilatory management in morbid obesity? These are the absolute goals that we must remember while taking care of any patient with morbid obesity. One is prevent hypoxia during induction, prevent and reverse atelectasis, maintain lung recruitment, prevent reoccurrence of atelectasis, avoid lung overdistension, and maintain post-op lung expansion. I'll speak very briefly about each of this because this is very important to the perioperative management of these patients. How do we prevent hypoxia during induction? Head end elevation 30 degrees. Using CPAP during induction. So we begin to pre-oxygenate the patient with CPAP. So maintain that positive end expiratory pressure or the continuous positive airway pressure right from induction and pre-oxygenate with 100% oxygen. And this would give you that little bit extra time to maintain safe apnea period during induction. How do we prevent or reverse atelectasis? Don't use very high FiO2, as low as you possibly can, so that you prevent high oxygen-induced lung atelectasis. Also, do recruitment maneuvers during the surgery. Soon after intubation and when you assume a different position, either Trendelenburg or reverse Trendelenburg, do recruitment maneuvers. Personally, I prefer to do stepwise gradual recruitment of the lung, but various methods of recruitment have been described in literature. And then maintain that recruitment with PEEP. So somewhere around 10 to 12, but then like I said, individualize this. So you may have to go up to 15 or 16 in some patients. It's all about balancing oxygenation and carbon dioxide while maintaining safe lung pressures. And then prevent the reoccurrence of atelectasis by intermittently recruiting the patient, especially after intubation, after establishment of the pneumoperitoneum, when the surgeon causes pneumoperitoneum, and when the clinical picture seems to suggest that there is some lung collapse happening or atelectasis happening. That's when you would establish and re-recruit the patient and then maintain that with PEEP of 10 to 12. How do I avoid lung overdistension? Be careful with the tidal volumes that I'm using. So 6 to 8 up to 10 ml per kg. Keep the end expiratory pressure below 30. So if I'm having to use increased driving pressures to wash out the carbon dioxide, I would rather increase the respiratory rate than increase the driving pressure and increase the total lung pressure. Allow, accept mild hypercarbia if necessary. So it's all about finding that right balance. And post-operatively, continue to maintain that lung expansion. So use CPAP or BiPAP immediately after tracheal extubation. So the key is remove the tube with one hand and immediately place the BiPAP mask with the other hand. Keep the upper body elevated and ensure good pain relief. All of that will help to open out that lung and help the patient breathe better. Using in-center spirometry and encouraging early ambulation will help that post-operative phase. Coming to analgesia, that's a big area that we need to take care of intraoperatively. So we know that the ERAS protocol and many protocols in bariatric surgery recommend reducing or even eliminating the use of opiates during and even after surgery. Now, how do we do that? We use a lot of other adjuvants. We use acetaminophen, non-steroidal anti-inflammatory drugs. We can use ketamine infusions. We can use alpha-2 agonist infusions. We can use lignocaine infusions. We can use magnesium IV. Use local or regional anesthetic techniques like epidural and tap blocks or wound infiltration, and even intraperitoneal infiltration of local anesthetic. All of this will help reduce the opiate consumption during and after surgery. Some other considerations, important points to remember would be using the right volatile agents. Desflurane is excellent to help rapid recovery, and a patient is wide awake at the end of the surgery. Also, monitoring of neuromuscular block is very essential because, like I said, we don't really know what is that right dose. How do we base that dosing of these drugs on? And if you use too high neuromuscular blocks, this can have disastrous problems it can cause in the post-operative period. Go with moderate, judicious use of IV fluids, especially as the ERAS protocol recommends, and ensure complete recovery of neuromuscular blockage before we extubate the patient. And for this, again, counseling the patient and talking to the patient is very important. Actually explaining to them all the steps of the surgery and anesthetic management will really help them and help them cooperate with you and your shared goals together. Continue with post-operative non-invasive ventilation and monitored post-op stay. This is the gist of the management of morbidly obese patients coming in for surgery. I would like to share a case scenario that was a really challenging case to all of us, including Dr. Sujit, who performed this surgery. And this was such a landmark case for us, and it taught us so much about the management of anesthesia in morbidly obese patients. Now, this was a 32-year-old gentleman who was an IT professional who weighed 225 kilos when he came to the hospital. And so he came under the category of the super obese. He had a BMI of 67.5 when he came to us. And this was a real challenge for all of us. And the planning took 8 to 12 weeks prior to the actual date of surgery. And so as far as the anesthetic management went, we did a detailed anesthetic assessment 8 weeks prior to the surgery. And we identified some of the issues that we were up against, that is OSA and OHS. The patient had metabolic syndrome, especially diabetes, fatty liver, and NASH. He had mild restriction on PFT. His echo was normal. Fortunately, there was no pulmonary hypertension. His chest X-ray was good, and angiography revealed normal coronaries. He was on Adolin nebulization, melatonin tablets, clonidine, and metformin for the metabolic profile. He was also on stress ulcer prophylaxis and aspiration prophylaxis. He was using DVT prophylaxis like compression stockings and low molecular weight heparin. And the pre-op ABG revealed mild hypoxemia with some borderline high carbon dioxide levels. He gave a clear history of OSA and OHS, and he was initiated on elective nocturnal non-invasive ventilation before surgery so that he would get used to that process and it would offset some of the airway problems that we were anticipating in the perioperative period. This patient was also begun on incentive spirometry, and we had an excellent team of physiotherapists who began working on him 12 weeks prior and began rehabilitation exercises, which significantly improved his exercise capacity. From being breathless on getting up from the bed and going to the bathroom, he was able to walk up to 10 minutes without breathlessness. And he had a much better sleep cycle, and he attained a weight reduction of 8 to 10 kilos. His room air saturation at rest was 91%, but it was dipping to 87% while walking. His mouth opening, Malampati score, neck extension, and circumference didn't predict a potentially difficult airway. So once that 8 to 12 week preparatory period was over and we were ready to take him up for the surgery, we did a mock drill and a rehearsal with the patient and the entire operative team. So all the personnel involved during the surgery, the entire perioperative period, were brought into the picture early on. And we discussed the various options of how we would manage the intraoperative period. And so we brought the patient into the theater, into the actual OT where he would be operated on. We checked the fit on the OT table, and we tried the various tilts and various positions preoperatively. We ensured that he fit into that special extra large bed that was arranged specially for him. And we made sure that the bed moved seamlessly from the theater to the ICU. And we actually took the bed across all these areas just to make sure that we wouldn't face any obstruction anywhere. We made sure that the patient had the appropriately sized bed and the air mattress. We planned by making sure we had additional operating room personnel, which means we had 2 anesthesiologists, 2 anesthesia technicians, 2 OR technicians, and nurses for the surgical procedure. The safety briefing for everybody concerned made sure that we all understood what the proper position, what equipment, what approach we would be using, what was the surgical procedure, and where the patient would go after the surgery. The patient was actively involved in every step, and he knew exactly what the anesthesia involved. And he was even told what we would instruct him to do once he woke up out of the anesthesia, and that he would have a tube in his throat a little bit longer than normal, but not to panic. That was a patient undergoing that mock drill. So we made sure we could actually even hold the mask, and we checked how the mask fit was and the fit on the table was. We made sure that we had extra equipment, and we had custom made tube pillow for this patient. And 2 theater tables were put into that theater so that we would achieve appropriate maximal weight allowance. Extra oxygen cylinders were available so as to improve the apnea time by increased delivery during induction. We have a very good machine, anesthesia workstation, which is accurate, high precision piston ventilator mechanics, which would ensure that we got low and minimal flow anesthesia, which was lung protective, of course. And we got the desk floor rain vaporizer and the top monitor, and we had adequate padding and pillow to make sure that we prevented pressure sores and nerve injuries. This was all the equipment that we set up on the day prior to surgery. So we made sure that we had everything ready, including the little microport tapes that we needed to tape the eyes for the procedure. We had the blood warmers, all the syringe pumps, and the infusion sets and the air blankets, etc., etc. Drug pharmacokinetics was one area where we were really worried about. So as you can see, we calculated his ideal body weight, his lean body weight, and his adjusted body weight. And then we took off each of these drugs and then dosed his drugs based. So we checked what drug dosage would we be using, and we made a chart for that. And so that we knew what drug should be given at what dosage based on what body weight, whether it was lean or adjusted or ideal body weight. And we calculated that for this patient for all the drugs concerned. Yeah, and so when the D-Day arrived, we were prepared as best as we could. And of course, the patient was so cooperative. Before intubation, we ensured that the patient assumed the true position. We pre-oxygenated with CPAP, 10 centimeters of CPAP, and used 100% oxygen for 5 minutes. Intubation was done with a video laryngoscope. We ensured apneic oxygenation was maintained with an additional oropharyngeal cannula provided from an additional oxygen cylinder. With this, we got an apnea time of 15 to 20 seconds. We intubated the patient without any problems using a bougie and an endotracheal tube size 9, following which we inserted central venous cannulae and arterial cannulae. We used the ECG, the intraarterial blood pressure monitoring, temperature probe, saturation, neuromuscular monitoring. We monitored the MAC, ETCO2, GRBS, and urine output. Drug pharmacokinetics, in the very simplest way, we used actual body weight for succinylcholine, lean body weight for ventilation, and the adjusted body weight for most drugs. But then again, most literature mention drug dosing up to a BMI of 50 or 55. We were dealing with a BMI of more than 65, and the literature is literally mute about those kinds of BMIs. The optimal method for calculating weight-based doses of many medications is unclear, with limited available literature. And so that's an area of research that probably we could look into. This was the patient after we had positioned him, after we had intubated him on the day of the surgery, and we were beginning the surgical part. That's a picture to show you the number of pumps that we were using. Most of this were for analgesics, non-opiate analgesics. So we were on ketamine, dexmedetomidine, and magnesium, besides, of course, the neuromuscular relaxant. Just to give you a glimpse about how difficult ventilation was, we did use pressure control ventilation in the lung protective strategy, like I mentioned. But after pneumoperitoneum was initiated, initially it was a little more easier, but by the time it was 4 to 5 hours into the surgery of pneumoperitoneum, we faced some real problems. So mainly with the balance between carbon dioxide and oxygen levels. So as you can see, we were using pretty high peeps of close to 14. Our PNs was close to 43. Our FiO2 was 65%. We had a frequency of 16. We were using short I times, much longer E times as we possibly could. And ETCO2 was 50. I think towards the end of the surgical part, our ETCO2 was even higher than that, but we had to just allow it to happen. It was mostly permissive hypercapnia. But because the patient was young and was well prepared for the surgery, exercised, etc., he tolerated all of this very well. We did do a lot of recruitment maneuvers, especially after intubation and after pneumoperitoneum was established. We maintained anesthesia with air-oxygen mixture and desflurane. We did use fentanyl and morphine dose sparingly, and we spared opiates by using ketamine, dexmedetomidine, magnesium, paracetamol, and intraperitoneal ropivacaine, with also infiltration of wound sites with ropivacaine 0.2%. Vecuronium was our muscle relaxant, which was guided by PTCs and TOF monitoring. We maintained blood sugar close to 120 to 160 milligram percent. Of course, ABG was maintained and monitored. We used a restrictive fluid strategy and ensured active warming with air blankets and fluid warmers. He maintained very good urine output throughout the procedure, and his IO balance was perfect. Post-operatively, we returned the patient to the true position, and after ensuring that he was awake and following commands with the muscle power of 5, we extubated him directly to NIV with bilevel positive airway pressure of 18 and 12. And NIV was given electively overnight. He was nursed in the ICU. We also supplemented analgesia with infusions of fentanyl, NSAIDs, and acetaminophen. Of course, in the post-operative period, he was continued on exercises, mobilization, PMR care, dietary care, counseling, and psychological support. All of this went such a long way in his rehabilitation and his eventual recovery and going home. He was mobilized and made to walk and give chest physiotherapy from day 1 of the post-operative period, and he was started on oral liquids by the first post-operative day and was gradually increased. The graded intensive physiotherapy continued throughout his hospital stay. Happily for us, the liver functions normalized by a week, and sugars were controlled within the first week. He was discharged from the hospital at the end of 3 weeks. What is the take-home message from this presentation? So if there is a few things that it would really help us to remember, especially when we're dealing with obese patients and the morbidly obese patients, is that obesity is a multi-organ disease. It's not just the GI that's involved, but so many components, including the psychological and the neurological components of obesity. And obesity can pose significant anesthetic challenges, especially the pulmonary and the cardiac part. And I cannot overemphasize the importance of safe and individualized perioperative care. There is no one slot that we can fit our patient into. We have to tailor the patient and the surgery and the needs of the patient so that it is a perfect fit for that particular patient. The challenges of pain management and, of course, the team effort in the care of the patient. All of this is very important. And so more than any one drug or any one particular way of managing the patient, it is all of this and more. I just want to leave you with a picture of this patient going home, and there was a small function that was arranged. And these were all the doctors and nurses who took care of this patient from the various departments of the hospital. And each person was so important in the care of this patient and contributed to him going home. Thank you very much.
Thank you, Dr. Ashu, for beautifully covering this topic and for sharing your experience with this extremely challenging case. So I would request all the listeners to put in your questions into the chat box so that can be answered in the question answer session. Before we move on to the question answer session, I would request Dr. Sujit to please share your experience of bariatric surgery and its outcomes in our institution.
Good evening. Thank you, Dr. Jinsi. Thank you, Dr. Ashu, for that very comprehensive presentation, and you completely covered most of the topics, and it was very useful for the surgical faculty also. And regarding experience in our institution, we are done at Believers, we are done 24 cases with acceptable morbidity and no mortality. Um, we have I have passed our learning curve. The learning curve is around 20 cases. We have passed the learning curve, and the surgical steps have mostly been sorted out well. Another important person which I want to mention in our team is the surgical nurse, because the surgery involves a lot of instrumentations like staples and how to position. So the surgical nurse also plays an important role in our team. So we have one fixed nurse who has been there for the past 5 years, and she has played an important role in managing things from positioning, the instrumentation and all. And other thing I would like to say is the surgical steps mostly we can control, but the it is the post-operative things which you don't have control. We may not be able to control the any cardiac issues post-operatively to the extent we can control as surgical issues or respiratory issues. We put in our best effort, but in spite of best efforts, something can happen. Um, and the final point would be, it is a team. The surgeon uh, alone cannot function and bring out good results. Everybody plays an important role. The anesthetist, the PMR team, the nurses, the critical care unit, everybody has to play their own role. Then only we'll be able to bring out a good result. And if we look at the ERAS implementation protocol, uh, yesterday, actually, the Manipal Hospital became the first hospital to get accredited for ERAS. So if you go through the society guidelines, they see that it is mandatory to have a team. It is a team that gets the accreditation, and it involves not only the anesthetist and the surgeon, but the other people involving the surgical nurse. So they have to get trained for 8 to 10 months and go to 4 seminars before we get accredited. So the key point is that it should be a team who is routinely during the doing the cases. So one person just cannot. If one person misses out, actually the whole team misses out. Yes. So these are some things which I learned over the past few years at Believers Hospital, and it has also. So I've been fortunate to be involved in bariatric surgery from 2005. So I was able to assist open bariatric surgeries also with the father of bariatric surgery in India. His name is Dr. Dore Patil from Pune. So at that time, I was able to assist him for open bariatric surgery cases, and so how the post-op things went. So it has changed a lot. How the pre and post-operative care came about has changed a lot during the last many years, and now ERAS is the way to go forward, and it has really helped in bringing down the post-operative complications. So yes, the care continues to be changed, and the emphasis is now on proper rehabilitation, good assessment, and an early discharge. And for that, the whole team has to function as a single unit. So that's what we have learned during the last many years.
Thank you, Dr. Sujit. I would once again request the listeners to put in your questions, if any, so that we can discuss for the question and answer session. Since we do not have any questions yet, I would ask Dr. Ashu. Ma'am, you've described a very challenging case of super obese patient. What would you say was the most difficult aspect of managing this gentleman?
So as far as the anesthesiologist's perspective, as far as the anesthesia part is concerned, I would say that the most difficult thing was the management of the ventilation. That was a real challenge. And I think the more obese category they get into, the more difficult it becomes to manage the ventilation. And so really it calls for your entire lifetime of experience to know how to ventilate this patient, especially when you have that pneumoperitoneum and when the whole diaphragm is shifted cephalad and you have airway collapse happening, and you watch PCO2 rising and your airway pressure is rising. And so you just have to bring in all your experience and manage that ventilation part. Of course, most of our patients don't fall into this super obese category. Those are the real challenging cases. But still, I would say ventilation remains the key there as far as challenge is concerned.
Thank you, ma'am. I think the presentation was really covered everything that none of the listeners had any questions to ask. So I guess we could wind it out. So with this growing prevalence of obesity, I think each and every anesthesiologist need to be aware of those pathophysiological changes and its implications when it comes to anesthesia. Because we are likely to see more and more individuals coming for surgery, whether bariatric or otherwise. So all that we heard today, including the rehabilitation, the preparation from the multimodal team approach, the ERAS protocols, the airway management, ventilatory strategies, diagnosis and attention to sleep apnea. Each of this goes a long way in the outcomes for an obese patient. So I would like to thank each of you, Dr. Ashu, Dr. Sujit, and Dr. Vivek for this lively discussion. And over to you, Dr. Vivek.
I think Dr. Vivek seems to be having some internet issues. So I think let's end this session. Thank you very much. Thank you once again for this opportunity. Thank you.
Thank you. Thank you.
Thank you.